Oral submucous fibrosis is an OPMD or oral potentially malignant disorder, which is prevalent in our region or South Asian countries. And as dental professionals, we come across at least few submucous fibrosis patients daily. Since submucous fibrosis is a challenging disorder to treat successfully, this is an attempt to update you on management of submucous fibrosis. Today we have a familiar speaker to this webinar series, Professor Ruwan Jayasinghe, who delivered the first webinar of this series. He needs no introduction to Sri Lankan community of dental professionals. But as a formality, I would give a brief introduction. Professor Ruwan Jayasinghe is the Chair Professor of Oral Medicine and Periodontology, Faculty of Dental Sciences, University of Peradeniya. Also, he is a consultant in oral and maxillofacial surgery. He has held many academic and administrative positions in faculty and also in University of Peradeniya. He has contributed to many national and international forums and received multiple awards, including Presidential Awards for Research Publications. Professor Jayasinghe has co-authored several books, including chapters, and published more than 75 local and international papers. His main research interest is on oral cancer and oral potentially malignant disorders. He has involved each and every steps of OPMD research, including prevention, etiopathogenesis, diagnosis, and novel management methods. Without taking much time, I would like to invite Professor Jayasinghe to deliver the presentation. Over to you, sir.
Thank you, Prasangi, for those kind words of introduction. And before I start the presentation, first, we would like to apologize for the small delay in starting the presentation. Number two, I would like to thank this young and energetic team who are basically helping us and doing everything behind the screen. Dr. Sumudu Medawela, he came up with the idea to start with, and then he set up the entire thing for us. And then Dr. Prasangi Peiris and Dr. Anushan Jayasinghe, they are helping us a lot in conducting these webinars, and I'm sure that these webinars will be very helpful for all of you. So today we are going to discuss the oral submucous fibrosis challenges in the management. We know oral submucous fibrosis is insidious, chronic, as well as a progressive disease characterized by the fibrosis of the submucosa. It is considered as an oral potentially malignant disorder. Oral submucous fibrosis is a major problem in this part of the world. Indian subcontinent, that is the main place where we see the oral submucous fibrosis. Even in Sri Lanka, the oral submucous fibrosis is a major problem. Etiopathogenesis of the oral submucous fibrosis is multifactorial. Ericanat chewing, whatever the formulation that we use, is the main causative agent in the causation of oral submucous fibrosis. In addition to the ericanat, there may be other contributory factors, but they are not the main etiological factors. These contributory factors include the chewing of smokeless tobacco, high intake of chilies, toxic levels of copper in the foodstuff, vitamin deficiencies, malnutrition, anemia, and the genetic predisposition. This is the main culprit, the areca nut, which is abundant in this part of the world. Whatever the way that we use, because the different people use this areca nut fruit in different ways. Some people use it raw, some people use it dry, and sometimes it is roasted. There are different ways of using it. Whatever the way, whether it is the traditional way, alone or in combination with the betel quid, or the commercially prepared areca products, all these products can give rise to oral submucous fibrosis. The involvement of the oral submucous fibrosis is not universal in the oral cavity. It varies from place to place. The frequent locations of involvement are the buccal mucosa and retromole area. It also commonly involves soft palate, palatal phalangeal area, uvula, the tongue, and the labial mucosa. But the involvement of the floor of the mouth and gingiva is rare. Now, these are universal findings. But the clinical presentation, the involvement of fibrosis, the fibrous band, can vary depending on the type of the areca nut product that the people are using. What we are using right now is not what we are seeing right now is not what we get in Indian subcontinent. That's what our experiences are. And it may be associated with the different products or any other reason which we don't know. Clinical presentation of the oral submucous fibrosis will depend on the stage of the involvement. Most patients, they present with the burning sensation or intolerance to the spicy food. Whereas some people, they are having vesicles, especially on the palate, with loss of pigmentation. There can be ulceration in the oral cavity as well as dryness in the mouth. And all these are basically due to the fibrosis that we get in the disease. Fibrosis in the oral mucosa can lead to rigidity of the lips, tongue, as well as the palate, resulting in functional disturbances and difficulties. The patient will find it difficult to move the tongue here and there. The patient will find it difficult to use the lips and the soft palate. So therefore, the speech will be affected, the swallowing will be affected. The patient will end up with the trismus-restricted mouth moan. Depigmentation and depapillation are some of the problems that we are facing with. This complicated slide is basically a combination of etiological factors, histopathological factors, and the clinical features that we will get in the situation. The main culprit is the alkaloids present in the areca nut. In addition to that, the chronic irritation is also play a role in the development of the fibrosis. And the fibrosis will give rise to obliteration of the blood vessels and hypoxia, and they can lead to the changes resulting in the leathery feeling, woody feeling, or the fibrous bands that we are getting up with. Reduction in the oxygenal supply, nutritional supply that we will get due to the obliteration of the blood vessels can result in the epithelial atrophy, which is the main reason why the people are getting the burning sensation as well as the oral ulceration. And not only that, the epithelial atrophy is associated with the depapillation, depigmentation, blanching appearance as the malignant transformation is a major problem associated with the oral submucous fibrosis. There are different malignant transformation rate given in the literature, but we accept that it is around 10%. The study we conducted in our clinic, we have identified the malignant transformation rate to be around 8%. The pathogenesis in the malignant transformation is thought to be a multifactorial. And we know the areca nut is a well-known carcinogen. It is a group 1 carcinogen. So therefore, the areca nut can induce the malignant transformation in people who are with oral submucous fibrosis. But not only the areca nut, even the tobacco and alcohol that these people are using it can induce the changes further. So this is the study that we conducted in our clinic using our patients, and we have identified the malignant transformation rate in our patients is around 8%. And we have identified the duration of the habit that they were having and the level of dysplasia present in the initial biopsy. They were the main features associated with the malignant transformation. So the people who were having the dysplasia to start with, they are at a higher risk of getting the malignant transformation. So this is what is happening. The patient starts with the epithelial atrophy, and then the changes in the epithelium will give rise to epithelial hyperplasia, which can present as a white lesion in the oral cavity, and then that will transform into the epithelial dysplasia and later on in the oral cancer. The clinical appearance in the oral cancer is little different from the rest of the cases. We will discuss that later on. This process can be identified by different markers, but unfortunately, still we don't have a good set of markers which can be used as prognostic indicators. There are so many studies going on. If we can come up with a good set of prognostic markers or the markers for the malignant transformation, we will be able to recognize those patients at the early stage. So therefore, the management can be done better. And clinically, this is what is going to happen. The normal mucosa is transformed into the oral submucous fibrosis, and then they develop a OPMD. Mostly the leukoplakias and sometimes the erythroplakias. So the people who are having these leukoplakias or erythroplakias present in the top of the oral submucous fibrosis, they are at a higher risk of transforming into a malignancy than the people who don't have it. And this is what is happening under the microscope. You can see the changes. The epithelial atrophy transform into the hyperplasia and the dysplasia, mild dysplasia, then moderate, severe, and later on it will transform into a oral squamous cell carcinoma. This is a review article that we have produced early this year, which we try to discuss different aspects of the diagnosis and the management of oral submucous fibrosis. Right, now we will come into the diagnosis of oral submucous fibrosis. Diagnosis depends on the clinical features. Characteristic and diagnostic clinical feature of the oral submucous fibrosis is the presence of fibrous band. So when you have a later stage oral submucous fibrosis with the fibrous bands, with the restricted mouth opening, anybody will be able to diagnose it. But the problem comes with the early stage. The features can mimic various other clinical problems. Therefore, it's very easily can be missed. And not only that, most of the people who are with the early oral submucous fibrosis, they have the burning sensation and a little bit of a difficulty, and there is a tendency for them to go into a medical practitioner, and sometimes it is missed to anemia, because most of these people on top of the oral submucous fibrosis, they have the anemia as well. Some of the clinical features can overlap with the anemia, helping with the not helping with the diagnosis. The question is to do a biopsy or not. There are different schools of thought. Some people, they believe doing a biopsy is very important in the management of oral submucous fibrosis, whereas the other, they do not want to do a biopsy unless the patient is having a white lesion or at a risk of developing a malignant transformation. Why the people don't want to do a biopsy? Because when we do a biopsy, there is a possibility of getting the scarring associated with that. So therefore, that will add to the problem that the patient is having already. On the other hand, the biopsy is necessary for the confirmation of the diagnosis as well as to identify the presence of epithelial dysplasia. Then the people will say, okay, oral submucous fibrosis is a disease where you will get in the entire mouth. And we are going to do the biopsy only from one place. So how are we going to say whether the patient is having the dysplasia or not just by looking at one particular place? I don't have answer to tell whether to do a biopsy or not. But if you take the digital manual produced by the IAC and the WHO, which we use generally in our diagnosis whenever there is an issue, in this digital manual produced by the IAC and the WHO, it says the clinical diagnosis of OSF is based on the symptoms and clinical features. A biopsy should be taken to confirm the diagnosis and to rule out dysplasia and malignancy. The clinical differential diagnosis include the scleroderma, vitiligo, and anemia. Vitiligo is an immune-mediated problem where you will have an issue with the melanocytes, giving rise to depigmentation. But having pure intraoral vitiligo is extremely rare. So if the patient is having the vitiligo only in the oral cavity without the involvement of the skin, it is very unlikely to be the vitiligo when they don't have the skin involvement. So therefore, we have to see the history, whether the patient is using the areca nut, and we may have to do a biopsy whenever there is a doubt. Then the anemia. Anemia, initially clinical presentation can be the same, but the people who have anemia, they will have the other clinical presentations as well. Scleroderma, that can give rise to the scarring, but not only in the oral cavity, but also in the other parts of the body. Right. Now we are coming into the management of oral submucous fibrosis, the treatment of oral submucous fibrosis, which is the main area that I have to discuss. So the people with oral submucous fibrosis, there are people with oral submucous fibrosis, and there are people without oral submucous fibrosis. And I am failing in my if I don't add few words regarding the people who don't have the oral submucous fibrosis. This is the simplest group, easiest group where we can manage. So therefore, the primary prevention in people who are not having the oral submucous fibrosis is very important. How can we do it? By controlling the areca nut usage. In addition to the legal legislation we have on the tobacco control, alcohol control, we have to have some legislation on the areca nut control as well. Most of the people knows the danger of tobacco and alcohol, but unfortunately, majority of the people in the country, including some educated or even the healthcare professionals, their understanding in the danger of the areca nut is not satisfactory. So therefore, we have to improve the knowledge as well as the legislation in relation to the areca nut use. On the other hand, we have the people who are having the oral submucous fibrosis. And when we are managing the person with the oral submucous fibrosis, we have two main goals. Number one, treat the symptoms, reduce the symptoms, and improve the quality of the life. Because these are chronic problems with a lot of morbidity. So the burning sensation reduction, improvement in the mouth opening, and the correction of the dental problems, oral hygiene problems that the patient is facing with, correction of the nutritional problems, the prevention of the ulceration, all these are onto that. On the other hand, these people can end up with malignant transformation. So therefore, prevention of the malignant transformation is also important. So currently, the available treatment options can be divided into three: medical, physical, and surgical treatment options. But up to date, we don't have one treatment modality which we can say, okay, this is the gold standard. Whenever the patient is having oral submucous fibrosis, you go for this. That type of a treatment modality is not available, unfortunately. Therefore, the management of oral submucous fibrosis is a challenge. It's a challenge not only for the general practitioner, but also for the specialist. Treatment of the oral submucous fibrosis will depend on the degree of clinical involvement. When the patient is having the initial problems, we have to manage the patient with the habit intervention, and most of the time, very early cases, habit intervention alone is good enough. So the patient will get some improvement only with that. Whereas when the patient is having moderate to severe disease, which is irreversible, now we have to come up with the treatment modalities. We have to understand the people who are having the oral submucous fibrosis, initially we thought it to be a disease of oral cavity alone. But now we know it is not only a disease of oral cavity. It can have a systemic involvement as well. So therefore, our approach has to be a combined approach with which will help the patient in overall patient management. And we need extensive research into the management of oral submucous fibrosis. What we have right now is not good enough. Now, this is what we have proposed. Oral submucous fibrosis is no longer considered as an oral cavity disease only. The people can have various types of systemic problems, either primarily due to the areca products, where the areca can have effect on the upper part of the aerodigestive tract as well as on the liver. On the other hand, there can be indirect effect, mostly coming through the nutritional deficiencies. There are different treatment modalities. The commonest method is steroids. There are different steroid preparations that is in use. There are various types of enzymes. There are different types of drugs, mostly the nutritional therapy, vitamins, antioxidants, pentoxifylline, interferon gamma. Then we have various types of nutritional interventions, turmeric, immunized milk powder, lycopene, aloe vera. And then there are so many different types of surgical interventions. It may be a simple surgery, or it may be a complicated surgery like microvascular surgery. And then we have the physical interventions as well. Steroids. This is the commonest treatment modality. We learn this as a student, and even today we are using the steroids as a treatment modality. But again, there are some controversies regarding the use of steroids. Different preparations are there. Some preparations are simple applications, the topical preparations, whereas some other are intralesional injections. So the possible actions of steroids is via the immunosuppressive action of the steroids. It will prevent or suppress the inflammatory reactions. It will minimize the fibrosis. It will enhance the fibroblast immune-mediated pathways, as well as they will decrease the fibroblastic proliferation and deposition of collagen. The topical agents, the commonly used topical agents are the triamcinolone and the betamethasone. And these topically applied steroid creams may relieve the early symptoms, inflammation, and mucositis. But they are not effective in reversing the fibrosis in advanced oral submucous fibrosis. So if the patient is having the fibrous bands, the effectiveness of these topical agents are very limited. Whereas the intralesional injections, where we may use triamcinolone, dexamethasone, methylprednisolone, hydrocortisone, all these can improve the symptoms, the burning sensation, as well as the mouth opening. So this is good enough in moderate to advanced disease. But on the other hand, the people are worried. We have to give these repeated injections. So therefore, the repeated needle tract trauma may cause additional scar tissue formation. So therefore, whether we are aggravating the problem, whether we are making it worse by giving the repeated injections. So whenever we are deciding to go for an intralesional steroid, we have to decide whether we are going to go for a short-acting or a long-acting preparation. The short-acting preparation, the advantage is that we don't get much of a steroid-related complications, but on the other hand, we have to use multiple injections at a time, whereas long-acting steroids will be better for that purpose. So in our clinic, we are using the intralesional steroid injections a lot, and we have analyzed these patients and we have identified a significant improvement in the mouth opening as well as other clinical parameters by using the intralesional corticosteroids. Not only us, there are many study findings to support the use of intralesional corticosteroids. Then there are various enzymes. We have the hyaluronidase, chymotrypsin, collagenase, and all these are basically interfering with the collagen activity. Hyaluronidase is basically breaking the ground substance, and by breaking the ground substance, it will not allow the collagen fiber complex to be formed. But unfortunately, the hyaluronidase is short-acting, and the people have shown a very good results when you combine the hyaluronidase together with the steroids. Antioxidants. And we know the antioxidants are very important in the causation of the malignant transformation. So therefore, the treatment with the antioxidants can help not not only to improve the symptoms of the disease, but also to minimize the possibility of a malignant transformation. The most commonly used antioxidant is the lycopene. Lycopene is a photochemical synthesized by the plants, mostly by the tomatoes. Most of the commercially prepared lycopene is a derivative coming from the tomatoes. It's a powerful antioxidant. It is 2 times powerful than the beta carotene and 10 times than the alpha tocopherol. The research has shown a very good improvement in the symptoms and the mouth opening, and they have not reported any side effects or intolerance to the lycopene. Whereas the people has shown some intolerance to other antioxidants like beta carotene. And we are conducting some studies using the various types of herbal products, and some of these herbal plants are showing some promising results in the laboratory level, but unfortunately still this has not been put into the clinical practice. We are planning to do it in the near future. Vasodilators. The most commonly used vasodilator is the fentoxaphylate. It dilates vessel. It promotes the fibrinolysis by increasing the fibroblast collagenases activity and decrease the collagen, fibronectin, and glycosaminoglycan production. Neutrophil degranulation, and it will help in the release of peroxidase, promote natural killer cell activity, inhibits production of tumor necrosis factor, T and B cell activation. So by all these, that will help in basically the vasodilatation, and with the vasodilatation you will get the reduction in the inflammation. Different regimes are there, but the usual regime to use 400 milligrams 3 times a day for a month, followed by 400 milligrams 2 times a day for 6 months. So altogether the patient has to take the treatment for 7 months. And with the fentoxaphylline treatment, they have shown a very good results, and there will be improvement in the clinical symptoms. But there are some adverse effects, mild gastritis, gastric irritation, as well as peripheral flushing, but these are not major side effects. The biggest problem that we are facing in our hand is the cost. This is little expensive drug, and most of the people who are having the oral submucous fibrosis, they are not the rich people, and they find it difficult to afford these drugs. Curcumin. So many studies are going on with the curcumin, and the studies have shown a very good results with the curcumin. There are different preparations of the curcumin. There are mouthwashes, there are tablets, whatever the preparation, whatever the dose that they use, the curcumin has shown some good results in the management of oral submucous fibrosis. Not only the medical management, we can use the physical therapy as well. The aim of the physical therapy is to influence the tissue remodeling using the movements, including the regular exercises and physiotherapy. There are various types of splints and other devices to improve the mouth opening. In addition to these splints and devices, the localized heat therapy using the microwave diathermy and ultrasound therapy also has been used. We are trying to develop a physiotherapy device to help the people with oral submucous fibrosis, and we have completed the modeling part. Now it's almost there to use in patients. Effectiveness of the treatment. Now different people will say, okay, this is effective, that is effective, I am treating with this and I have good results. But if we are going to do the evidence-based practice, we have to have evidence coming from the research. Unfortunately, the studies that they're having on the oral submucous fibrosis management, the research studies are different in the study design. So therefore combining them, analyzing them together is not an easy task. There are only very few properly conducted randomized double-blinded clinical trials with adequate sample size. And not only that, in most of these studies, there's a differences in the assessment of treatment outcomes. Some people just measure the mouth opening, whereas some people has used the subjective measurements, asking from the patient, are you having the improvement in the burning sensation? So that type of a subjective measurements. And most of these studies, almost all of the studies has not looked into the effects on malignant transformation of these various treatments. Sometimes We don't know. We may be getting a good clinical improvement, but it may promote the malignant transformation. So therefore, long-term follow-up is necessary. The people who are having the oral submucous fibrosis, they can develop transformations. And one problem before they develop into the cancer is the clinically malignant looking exophytic lesions, exophytic verrucous hyperplasias, which is a type of verrucopapillary lesion. And these lesions mostly looks like a malignancy. And repeated biopsies will show you there is no malignancy. And on top of that, even sometimes when the patient is having a malignancy, you will see the same appearance because they have a very thick porium. So therefore, the malignancies will pop up. They will not have much of a invasion going deeper, whereas they will come up. So they are basically exophytic in nature. So differentiating these are really difficult. So I have tried to summarize the different treatment modalities available and try to put it into one slide. We will get the people with oral submucous fibrosis and they will come to us in a different stage. So these are the different options that we can use in different stages. Remember, this is just the summarized slide, and depending on the patient, we may have to change this. This is not a 100% management guideline that I am giving you. So when the patient is having a grade 1 or a mild dysplasia, mild oral submucous fibrosis, where the mouth opening is satisfactory, those people can be treated with the habit intervention, nutritional therapy if they have any nutritional deficiency, improvement of the oral hygiene, and topical steroid if they are having the burning sensation and the oral ulceration. When the patient is having a grade 2 or the moderate disease, where the mouth opening is restricted to 20 to 35 millimeters, those people will be benefited from the antioxidants as well as the steroid, either topical or intralesional. And when they have the grade 3 lesions, severe restriction in the mouth opening, those patients can be managed either by the antioxidants, intralesional steroids, physical therapy, or the surgery, or combination of surgery and physical therapy. And when the patient is having oral submucous fibrosis with other potentially malignant disorder, the biopsy is mandatory, and those patients can be treated with antioxidants as well as the surgery to remove the lesion. When the patient is having epithelial dysplasia on the biopsy, those people can be managed by the antioxidant as well as the fentoxifilin. When the patient is having oral submucous fibrosis and a cancer on top of it, the management will be surgery. But doing the surgery is not a simple, easy procedure because they have the severe restricted mouth opening as well as severe fibrosis. Future. Whenever we are planning a future study in the management of oral submucous fibrosis, so whenever we are coming up with a new treatment modality, we have to consider the cost. Because most of the people who are having the oral submucous fibrosis, they belong to the poor socio-economical groups. So if we come up with a very expensive treatment modality, majority of the people will not be able to take it. And providing the treatment by the government sector will not be that easy because the numbers we are talking about, not just few numbers, the larger number of people will be there. And then we have to consider the time taken. If we are having a treatment which will take months and months to come with the effect, the people will not take it. They don't want to do it. They will give up after a month or two. So therefore, we need something where the taking is easy. Whenever we use aggressive therapy like surgeries, the patient's compliance is not going to be that good. Naturally occurring compounds with the antioxidant properties will be the best option. So that will be the future. Right now, there are many studies going on the curcumin, how it is affecting the system. So like aloe vera, tea pigments, they have shown some promising results even right now. And not only this, there may be other naturally occurring compounds, antioxidants, which will have an effect on the management of oral submucous fibrosis. And we need to test these in a large clinical trials in Asia, different parts, different countries, because right now the studies are restricted to smaller number of people. Whenever we are using the topical medication, like a steroid preparation, which we are give ask the patient to apply in the oral cavity, the penetration and the absorption is poor, simply because they have a very thick fibrous connective tissue. So therefore, the efficacy of the drug will be poor. So we have to come up with a mechanism to improve it. So now they have developed a mucoadhesive buccal films, mostly to be used together with the non-steroidal anti-inflammatory drug. So if we can combine them together, the management treatment option for the oral submucous fibrosis with these and apply into the buccal mucosa, then it will be much more beneficial. Antifibrotic drugs, it has shown some good effects with the other systemic conditions where you have the fibrosis, but it has not been studied in the oral submucous fibrosis. So some of these are good agents for us to check and see whether they are effective in submucous fibrosis as well. Now, there are so many studies going on the molecular mechanisms, and we are understanding the molecular mechanisms behind the etiopathogenesis of the oral submucous fibrosis very clearly. So therefore, we can consider these molecular targets and come up with the therapies targeting these specific molecules for the future. OSF remains a refractory for most of the medical therapies tried so far. But we need a better treatment modality to come up with better treatment modality for the future. So we need more and more trials, and we have to come up with a better medication to use in the oral submucous fibrosis. Thank you. I was trying to cover up, summarize the management options available in the management of oral submucous fibrosis, which is a very difficult task because we don't have 100% approved, agreed treatment options, but you know the different options that we have. So whatever the option, you have to decide depending on the patient, depending on the clinical situation, and depending on the facilities available to you. Thank you very much.
Thank you very much, sir, for your very comprehensive presentation and also sharing your practical experience. And I would like to apologize from all our participants for the technical issues, and thank you all for staying connected despite the technical issues. So we have a lot of questions.
I'm sure.
I would like to start from our colleague, Chandira Gunasen has asked a question, and he had excellent presentation, sir. Are there any specific salivary markers for the diagnosis of submucous fibrosis?
Answer is no. Up to date, we don't have any.
Okay, let's move to the next question, sir. Then from Dr. Varun Prasangi, he has asked whether to get digital manual by IARC/WHO, where to get?
If you just search, Google search, you cannot download it. Is only on the online. It's not a PDF document. It's only on the web. So if you just type the digital manual for OPMD diagnosis, WHO, it will appear. It gives all, not only the submucous fibrosis, even the other problems, including the cancer. It gives you the clinical areas, especially with the photographs. It's a very good thing for you to see.
Another question from the same attendee, why the bands are palpable in posterior region?
That is where the disease process starts with. Now, if the patient is having the bands in the anterior mouth, definitely the patient is having the bands in the posterior mouth. The disease process starts in the posterior mouth and then it comes forward. Again, why this happens, we don't know. But the theory behind this, when you chew the areca nut, when we keep it in the mouth, it gets diluted in the saliva, it gets mixed up with the saliva, and the saliva will be pooled mostly in the posterior mouth. That is one theory, but in that case, you have to see most of the effects in the floor of the mouth. But on the other hand, the effect, when you are getting the effect while biting, the chronic trauma associated with the chronic inflammation, that may be the reason. Simply why we get it in that area to start with, and then coming forward, we don't know. And on top of that, if you look at the clinical presentation, we get it in Sri Lanka, we hardly see the involvement of the palate. Whereas in India, the involvement of the palate is very common. If you take the Sri Lankan patients, the involvement of the tongue is very common, whereas not in India. So there are geographical variations in the clinical presentations as well. We have to identify why it is happening, and we have initiated some project with some of our Indian colleagues to see whether there are some differences and identify why it is happening. If it goes well, we may be able to answer some of these questions.
Thank you for your detailed answer, sir. And the next question is from Mohammed Sasmi. Do the OPMDs in the background of submucous fibrosis pose higher or lower risk in malignant transformation?
It carries a high risk. So if you take the leukoplakias get in normal people, the malignant transformation rate is low. But if you take the leukoplakias present in the submucous fibrosis, their malignant transformation is higher. That is one of the most important risk factors in the malignant transformation of oral submucous fibrosis. If you see a patient with leukoplakia on top of a submucous fibrosis, this patient, the chance of ending up a cancer is very high.
Next question is from Hardik Shah. He's asking any role of colchicine tablet in submucous fibrosis.
Sorry, what tablet? I didn't get it.
They said colchicine, COLCHICIN. Maybe a trade name that they are using in India.
Sorry, I don't know.
It's colchicine, sir. It's colchicine.
I'm not very sure because we don't have I have not come up with a proper clinical trial onto that. To tell you the truth, I'm not very sure.
Okay, let's move to the next question, sir. Thank you. It's from Asad Iqbal. When to go for a surgical intervention? How he has several questions together. How to ensure long-term maintenance of good mouth opening post-operatively, and how much opening should be achieved intra-op, and how much reduction is expected post-op. How to maintain it and exercise for how long. So all the post-operative management is asked.
Now, when to go for surgery? Again, there's no clear guideline, clear-cut place where you have to go for surgery. We have to consider multiple factors. One, we have to consider the disease itself. If the patient is having a cancer on top of oral submucous fibrosis or erythroplakia, where the malignant transformation is very high, even a leukoplakia which showing a severe dysplasia, then surgery is very much indicated. There's no question. We have to go for the surgery to prevent the malignant transformation or to treat the cancer. That is one. That is the place where we don't have any disparities. So that's for sure. Then if the patient is not having those, when are we going to go for the surgery? The main indication to go for the surgery is extremely low mouth opening. If the patient is having a mouth opening less than 10-15 millimeters, those patients, the traditional conventional medical treatment will not help much. So those patients, due to the reduction in mouth opening, they will end up with other problems. So therefore, that is one indication for us to go for the surgery. But again, we have to consider the other factors. Doing the surgery for these patients is not easy. And when you do it, how are we going to cover it? You can't just do it and put a skin graft and come out. So you have to go for either the nasolabial flaps, or you have to go for a microvascular surgery. Some type of treatment has to be done. So whether we can do it and whether the patient is willing to do it. Nasolabial flaps, and sometimes they can give rise to scarring in the face. Not each and every, but sometimes. So whether the patient is willing to get the scarring done, and then the patient has to stay in the hospital. So all these factors will come in. But if I'm going to simplify it, the two main areas for us to consider the surgery, reduction in the mouth opening and the presence of cancer or the presence of a possibility of a cancer. These are the main areas for the surgery. Next question. What is the amount of mouth opening we are going to achieve during the surgery? As much as possible. If you can get 50 millimeters, get to 50 millimeters. But again, there are the difficulties. So whatever you can get, the maximum you have to achieve. What you are going to maintain, minimum of 30 millimeters. If the patient is having above 30 millimeters, 35 millimeters, that is satisfactory level of mouth opening. It's not the normal level, it is not the best, but it is a satisfactory level of mouth opening for the patient to maintain the day-to-day activity. How are we going to maintain? By having the physical therapy, which you have to start as quickly as possible. How are we going to do it? Whether we are going to use a specific device for it, a specific splint for it, or whether the simple popsicle sticks, wooden sticks, is depending on, again, the available facilities. But whatever it is, the physical therapy is necessary for those patients. Otherwise, the fibrosis can take place again, and the patient may end up with the same problem again. And second time surgery is a nightmare.
Then, sir, anonymous attendee is asking, what is the mechanism of action of antioxidants that helps in treatment of submucous fibrosis?
Antioxidants, the mechanism, there are multiple folds of the antioxidant therapy. One thing the antioxidant will do, before we go into the question, we have to understand how the disease process started. Antioxidants are basically preventing the different steps in the causation of the pathogenesis of the disease. So most of the pathogenic processes are related with the oxidation. So therefore, giving the antioxidants, we can block these pathological steps. And not only that, the antioxidants are very important to minimize changes in the epithelial cells, not only in the underlying connective tissue, but also in the epithelial cells. So that is why the antioxidants can minimize the malignant transformation. If you take all the other treatment modalities that we discussed, including the surgery, the steroids, or whatever, their effect on the malignant transformation theoretically is not there. But the antioxidants, they not only reduce the symptoms by minimizing the oxidation, minimizing the fibrosis by involving the oxidation processes. So these will give rise to a reduction in the malignant transformation by interfering with the epithelial changes. So that's how it works.
Thank you, sir. And this is a comment from Dr. W. Jayasinghe. Dr. Jayasinghe is saying that this is the most common form of OPMD found in Ratnapura district. In different areas within the district, the prevalence varies. And thank you for updating. And
right. I would like to add a comment onto that. Now, if you take the oral submucous fibrosis, and Dr. Jayasinghe and myself, we have gone into the community, and I know how the amount of work he is doing. When you go to the society, you see larger number of people with oral submucous fibrosis. But if you look at the number of patients we are getting in the clinic, that is not that great. So the people who are in the society and the people who are coming into the clinic is not one and the same. Unfortunately, when they are coming into the clinic, when we see them, they are in the advanced stage, not in the early stage. The early stage patients are in the clinic because the clinical symptoms are very limited in those patients. And when a daily paid worker, when they have a little bit of burning sensation, they will not stop their work, their daily income to come into the clinic. So we have to go to them. We have to prevent the disease occurrence as well as identify them at the early stage, do at least the habit intervention, and that will help us to control the disease than getting into the next stage. And one more comment, because I received a question before the presentation regarding the areca nut. Now, sometimes the people say the areca nut is the main culprit in oral cancer, which is not. Areca nut is a carcinogen which is associated with the oral cancer. It is one of the most important etiological factors. But if someone says it is the carcinogen, it is not correct. So we have to consider the others. Tobacco is number one. Whatever the form that we use, the tobacco is the most important carcinogen. And the activity will be enhanced by the alcohol as well as the areca nut. So alcohol, tobacco and areca nut, all three are important in the process. On the other hand, if you take the oral submucous fibrosis, it is the etiological agent. So these are two different things. For OSF, it is areca nut, whereas when it comes to the oral cancer, it's tobacco, then areca nut and alcohol.
Okay. Thank you very much, sir, for your comment. And from G. Bajai and Ashok Matthew, they are asking about some herbal products. Can the household turmeric powder be advised for patients with submucous fibrosis? And Dr. Ashok is asking any effects of ginseng.
The second part I will answer first. I don't know. Second part, ginseng, I don't know whether it is effective or not, because I have not come across any trial, any evidence for that. But for the turmeric, the different people are using the different preparations. I know some people, they use the household turmeric and use it. But when we use something, when you just get it from the nature and use it, we have to consider multiple aspects of that. There can be various other products with that which can have an effect. Now, for example, if you take the turmeric that is available in the shop or wherever, you can have the fungi growing into that. There can be bacteria growing into that. And those can have an effect on the oral cavity. Sometimes it can worsen the condition, or sometimes it can give rise to a different problem. And not only into the oral cavity, sometimes you can get the improvement of the oral cavity, but the patient can have an effect elsewhere. Then one can argue, okay, we are using it with the meals, so therefore, how can it be very toxic? We don't know. So from our point, I don't think that using it alone, using it in that form or the natural form is very advisable. Commercially prepared identification of the active ingredient and then managing with the active ingredient will be the ideal treatment.
Thank you, sir. And from an anonymous attendee is asking about etiology. The question is it possible that if someone has buccal flap partially removed due to third molar infection, does it contribute to the etiology in forming submucous fibrosis because the mucosa is continuously being irritated?
Oral submucous fibrosis, according to our understanding, according to the available science, will not happen anything other than due to the areca nut. There can be other contributory factors which will increase the problem. But the main causative agent in the etiopathogenesis of oral submucous fibrosis is areca nut. But on the other hand, you can get the fibrosis in the oral cavity. There are certain situations. Now, for example, I had a patient who was using the chewing gum continuously, and the patient was having the fibrosis and the restricted mouth open. So the person is getting the repeated trauma to the buccal mucosas, and these repeated traumas give rise to chronic inflammation, and the patient will get some fibrosis due to the chronic inflammation, and that will cause the restricted mouth opening. But that is not the disease that we are causing with. That fibrosis is not irreversible, and the fiber structure can be manageable. So when you take the cause out, and they will become normal after a while. And there's no malignant transformation potential associated with that type of fibrosis. So but when you look at for the first time, they looks like the submucous fibrosis. And even if you do a biopsy, the pathologists will see the same. They will see the epithelium is thinner and underlying fibrosis, because that's what they will get, the fibrosis. They are two different disease processes. So the rest, chronic irritation, can contribute to the development of submucous fibrosis and various other. They are not the etiological agents. The etiological agent is areca nut.
Thank you, sir, for sharing your clinical experience. And the next question is from Salisha. What are the contraindications for pentoxylin usage?
Pentoxylin, right now, there are no major contraindications other than the people who are having serious cardiac problems. So the cardiovascular disease is the major problem, because the vasodilatation can interfere with the normal cardiac function. So the people who don't have a cardiac diseases, you can use the pentoxylin.
Next question is from Kaushik. What are the possible surgery we can do over submucous fibrosis?
Sorry?
What are the possible surgery we can do over submucous fibrosis?
There are different types of surgeries. You can do the scalpel surgeries, you can do the laser surgeries. Different treatment options are there. Different people are telling the different things. But the most commonly used modalities, number one is the nasolabial flaps, and other one is the microvascular flea flaps. So those two are the common ones. And then the people are sometimes using reconstruct. Basically what we do, we take the fibrous tissue out, and the problem comes with the reconstruction. How are we going to reconstruct it? You cannot leave it grow, then the fibrosis will happen again. Now, so whatever the modality we are going to use, it has to reduce the fibrosis. Ideal will be the microvascular flea flaps.
Thank you, sir. And again from Ashok Matthew, he asked about many combinations of antioxidants. They come with lot of other constitutions. Just a comment, I think.
Yeah. True. That is the problem that we are facing with the commercial preparations. The companies, they want to be different from the other. So what they will do, they keep adding things without having any evidence. So we get lost with the preparation. So for example, if you take the curcumin, there are multiple preparations with the curcumin. So because one person will get the patent and they are producing it, that the other person wants to use something else. So that what they will do is they will add something, and without having any evidence. So those, we have to be very careful when we are using the preparation, and it is very important for us to read what is there in the small letters.
Thank you, sir. And from an anonymous attendee, is asking how enzymes given to patients.
By injections, by intralesional injections. I have not used it, but that's how they use it. Or even sometimes the people use placental extracts. Now they are basically, placental extract is outdated technique and we don't use it now.
I think we have a question and a comment from Bhutan's our good friend Dr. Tenzin Udin, and she says in Bhutan we use intralesional injection of placental extract and steroid. So what do you think of that combination, sir?
It's a well-known combination. The people are using, but the popularity of that is getting less. Because most of the people, the reason for the popularity go down, the people don't like the placental extracts. So that is the reason. Otherwise, it's a well-known combination which has shown some good results.
Sir, another question regarding enzymes from Dr. Hardik Patel. How much significance of enzyme in submucous fibrosis, and which stages we can give it?
You can give it not only in the stage 1, but in the stage 2 and 3, you can give the enzymes. And the studies have shown a very good result, especially when you are using it with the steroid rather than using it alone. The effectiveness is much higher when you are using it with steroids. But if you ask about my experience, I have not used it. So therefore, in my clinical hands, I cannot tell anything about the use of steroids. So whatever I tell is coming from the literature that they have used. Not for the stage 1. If you are going to use it for the stage 2 and stage 3. And especially the cases where you are not in a position to go for the surgery, this is a very good option.
Thank you, sir. And a question from Dr. Dharmasena Hettiarachchi is asking about the prognosis of children OSF after cessation of habit. Please explain.
If you identify them at the early stage, and if you do the habit intervention, then basically you can expect them to be normal over a period of time. But if it goes to the second and the third stage, then they are irreversible and they will be progressive, and we don't know what will happen. When it comes to the malignant transformation, the age is a factor. Younger people will get the problem in a quicker time, and the younger people, the malignant transformation can be higher compared to the elder. That's why preventing it in children is important. Identification them at the early stage, then the malignant transformation will be poor. The pictures that I showed you, these are almost 10 years old now, and we are following them up for more than 10 years now, and none of them has shown any change. So they are basically doing well without any clinical problem.
Thank you, sir. And we have a very long list of questions, so I move fast. From anonymous attendee, he is asking, what is the best treatment we can propose to the patient which have low socio-economically status?
In that case, the steroid is a good option. Because most of the other options, if you ask the patient to buy from outside, they are expensive. And some of them are not freely available. So therefore, the steroid, either topical preparation or the intralesional preparations are much cheaper, and they give good results.
The next question is from Ashok Matthew. He is asking whether, sir, you have come across any patients with cardiac complications due to submucous fibrosis?
Answer is no. We have not come across any patients who are having a cardiac problem, and we have come across few patients with liver pathologies. And people believe the copper in the arecanut can induce fibrosis, cirrhosis in the liver, and it's a well-documented phenomena, and the people can end up with the problems in the upper part of the aerodigestive tract, especially the cancers. So far, the literature, there are no evidence to say the cardiac conditions can be associated with the submucous fibrosis. But we have to remember, people with the submucous fibrosis, they may be using tobacco, and most of the time the alcohol as well, and those can contribute to the problems associated with the cardiovascular system. It may not be anything to do with the submucous fibrosis.
And we have interesting question from Dr. W.A. Jayasinghe. Dr. Jayasinghe is asking, any study to show low incidence of diabetics in those who chew betel quid?
To my knowledge, the answer is no. I have not seen any. Because now when we are comparing the two, it is very difficult. We have to analyze multiple co-founders. Because the people who are having the low socio-economical group, they are the people who are at the risk of getting the oral submucous fibrosis. So they are the people who are chewing the betel, and they are the people who are at the risk of getting the diabetes as well. So therefore, we have to be very difficult area to study. I have not come across anything.
So even though we have a lot of questions, due to the restrictions of time factor, we should give the option to our audio questions. So over to you, Dr. Sumudu. Dr. Sumudu?
Yeah, so thank you, Prasangi. So we have a live question from Dr. Sridevi Navaratnam. Now I'm going to put her live.
Okay.
Dr. Sridevi, we can hear you. Dr. Sridevi?
I think her mic is muted right now.
Yeah, Dr. Sridevi, now we can hear you. Dr. Sridevi? Okay, so I think the line is disconnected. Prasangi, please. Prasangi?
Depending on the number of questions that we are having, I believe that if the time permits, somewhere next month or whenever we have the time, we have to have another discussion on the oral submucous fibrosis.
Okay.
1001 questions are coming up.
Okay, so we have another live question. Okay, also that also disappeared. Prasangi, please take over.
Okay, thank you, Dr. Sumudu, and a few questions regarding the exercise. From Dr. Patel, patient with 15 millimeter mouth opening, is conservative approach possible? Another question is, can we give mouth exercise by blowing balloons for 5 times?
The second part I will answer first. I don't know. We have not tried it, and I have not come across evidence for it. So simply the answer is I don't know. Blowing the balloon, basically what we will do, we'll have effect on the musculature, but whether the same effect will be on the mucosa, simply we don't know. And then the physical therapy, one thing that we have to consider when we are deciding on the physical therapy, the amount of fibrosis present as well as the status of the dentition and the temporomandibular joint. There's a limit that we can insert the pressure. If you insert too much of pressure with the physical therapy, that can have effect on the teeth, the periodontal tissues, and as well as on the temporomandibular joint. So this is a balance. So a person who is having a high level of fibrosis, a very low level of oral mouth opening, I don't think the physical therapy is going to work, because the amount of pressure that we needed will be very much high, and we will not be able to deliver that much of pressure. And even if you are going to do it, that has to be gradual, which will take a longer period of time, and the fibrosis will continue, and that can cause the problem. So if the patient is having a very low level of mouth opening and a high level of fibrosis, I believe the treatment will be the surgery.
I will move on to the last question, sir. From Vijay. What if we don't treat submucous fibrosis? Will it increase the chance of malignant transformation?
Yes, it is. If you don't treat the people with submucous fibrosis, when they comes to the stage 2, it will continue, and the patient's mouth opening is going to reduce gradually, and the patient will end up with other problems, and finally mouth opening will be 0, and they will have the problems. Number 2, the patient can transform into a malignancy. Now in our clinic, we are talking about the people who are on our follow-ups on the management, and still we see a 8% malignant transformation rate. And remember, these are the people who are receiving the treatment from a specialist center, who are coming for the regular follow-ups and getting the required treatment. And if it is 8% in our hands, I'm sure if you leave the patient outside, it will be much higher than that. On the other hand, if you look at the problem from the other side, in our setup, around 50% of the people who are having oral cancer, there is evidence of fibrosis in the background. So it looks like that most of the cancers we see are coming from the submucous fibrosis. Whereas the early cases, if you stop the habit, there is a possibility of maintaining it at that level without progression. But whatever it is, whether it is early stage, later stage, habit intervention is a must.
Thank you very much, sir. Thank you for your time and sharing your knowledge with us. And I'm sorry that we couldn't answer all the questions due to the restrictions of time, but the Professor Jayasinghe will follow the questions and send you answers to the email if possible. And we will wind up for today, and I am inviting you all for the next webinar on a pathological perspective on management of odontogenic lesions by Professor Prasangi Peiris, Faculty of Dental Sciences. Thank you all and good night.
Thank you. Good night.